everyone. My name is Pilantana Baxter. I am a Columbus State University NPSG student. Today, I will be giving a presentation on the National Patient Safety Goal 070601 of prevention of indwelling catheter associated urinary tract infection. For this presentation, I am going to talk about the following topic. What is National Patient Safety Goal 070601? Importance of prevention of indwelling catheter associated urinary tract infections. Case scenario. 3 evidence-based practice research articles. And finally, I will finish with concluding comments. What is NPSG 070601? It is the National Patient Safety Goal of implementing evidence-based practice to prevent indwelling catheter-associated urinary tract infections or CAUTI. Remember, this goal does not apply to pediatric populations because the evidence-based practice research was conducted with adults only. Okay, the National Patient Safety Goal highlights problematic areas in using indwelling catheter and gives evidence-based practice and guidelines for solutions to these problems. The first safety issue is insertion of indwelling urinary catheters. The goals provides evidence-based practice and guidelines for limiting use and duration using aseptic techniques. The second safety issue is managing indwelling urinary catheters. The goal provides evidence-based practice and guidelines for securing catheters to maximize urine flow and drainage, maintaining the sterility of collecting system, replacing the urine collection system, collecting urine samples, and the last safety issue is measuring and monitoring catheter-associated urinary tract infection or CAUTI preventing process. The goal provides evidence-based practice and guidelines for selecting ways to measure, monitoring compliance, and evaluating the effectiveness of prevention efforts. Now, why is it important to prevent CAUTI? UTIs are the most common type of healthcare-associated infection. Approximately 75% of UTIs acquired in the hospital are associated with a urinary catheter. 15 to 25% of hospitalized patients receive urinary catheters during their hospital stay. Greatest risk factor for developing a CAUTI is prolonged use of the urinary catheter. And how reducing CAUTIs improves patient outcomes. First, CAUTI can lead to other complications such as epididymitis. Next, CAUTI cause prolonged hospital stay. And the last one, CAUTI cause increased cost and mortality. Okay, now let's look at 3 evidence evidence-based practice research article. The first one was conducted at Stanford 300-bed community teaching hospital. Let's look at the detail. A multidisciplinary team conducted a study to reduce urinary catheter use and CAUTIs. They implemented a nurse-directed urinary catheter removal protocol that was linked to the physician catheter insertion order. 3 additional elements were added. The first one is physician documentations of catheter insertion criteria. Second, a device-specific charting module added to physician electronic progress notes. And the last one, bi-weekly unit-specific feedback on catheter use rates and CAUTI rates in a multidisciplinary forum. The result, they found that a 50% hospital-wide reduction in catheter use and a 70% reduction in CAUTI over a 36-month period. So what is my thought about this evidence-based practice? This evidence-based practice is similar to my hospital, but the computer at my hospital, it does not notify us to check. We usually assess the patient who has a catheter every shift to see that the patient still needs the Foley catheter or not. The second evidence-based practice, this is conducted in West Georgia Medical Center, 276-bed hospital. So let's look at the detail. The team implement a bundle of 4 evidence-based interventions for CAUTI over a 9-month period. And this hospital, they found 4 interventions. The first one is the exclusive use of silver alloy catheters in the hospital's acute care area. The second intervention is securing device to limit the movement of the catheter after insertion. The third intervention is repositioning of the catheter tubing if it was found to be touching the floor. And the last intervention is removal of the indwelling urinary catheter on post-op day 1 or 2 for a surgical patient. The result is, for the pre-intervention period, the mean rate of CAUTI per 1,000 catheter days was 5.2, and it was a decrease from 5.2 to 1.5 after they used this intervention. So my thought about this evidence-based practice is the last 3 interventions can easily be implemented on my floor with no cost. Alright, let's see the last one. The final article is a comprehensive review of literature for interventions to reduce the duration of catheterization and CAUTIs. They publish articles in databases such as MedLife, Cochrane Database, Google, and Google Scholar. From this research, they found 2 effective strategies to reduce CAUTI. The first one is The first one was using nurse-led intervention, and the other was use informatic-led interventions. So, what is my thought to this evidence-based practice article? This study gives credibility to the results of the two previous articles that I presented already. Okay, now let's look at the case study or scenario. So the problem is this was a 65 years old male patient, and then he came in with pneumonia. The patient had decreased mobility and a history of chronic kidney disease stage 4. The patient was scheduled hemodialysis on every Monday, Wednesday, and Friday. The emergency room doctor gave me an order to initiate a Foley catheter. But when I was about to initiate the Foley, I asked the patient and his family, his wife, about his urination pattern, such as how often, how is the urine output, urine retention. He and his wife said that he does not urinate or anuria in this case. So what did I do? Once I heard the patient does not urinate, I decided to check the hospital CAUTI guideline bundles, which is based on the National Patient Safety Goal 070601. And then I also decide to check with the renal nurse. The result is this situation did not fit in the valid reason, which is I show you with the next slide. This is not fit with the valid reason for the urinary catheter according to the hospital guideline. And also the renal nurse, she said that she would not give the patient, she would not initiate a Foley catheter for this patient. Also, she said she had this patient before, and the renal doctor already confirmed that we're not gonna give him, we're not gonna initiate the Foley catheter. Okay, this is actual the bundle for before we insert the Foley catheter in my hospital. So we will look at this. Does the patient has acute urinary retention or bladder outlet obstruction or not? Accurate measurement of urinary output in critical ill patient. Undergoing urologic surgery or other surgery. Does the patient anticipate prolonged duration of surgery? Does the patient have a unhealing wound stage 3 or stage 3 or 4 or not? And by the way, after I look at my patient and then his situation did not fit any of this scenario, so I did not initiate the Foley, but I also called the doctor and then let the doctor know what happened. Okay, the last slide. Let's see the conclusion. What have we learned? First, using intervention from evidence-based practice research can effectively reduce CAUTI. Second, many CAUTI interventions can be implemented at little or no cost. And the last one, nurse-led interventions are one of two most effective ways to reduce CAUTI. And these are my references. Thank you.